is good to see that we have
Yes,
several
please, sir.
members
We are
joining in
live on YouTube now.
from all over the country.
Good evening, one and all. I welcome you to this program. A special welcome to our senior leaders from All India Ophthalmological Society, Namrata Madam, Rajesh Sir. Our special welcome to senior members and office bearers and leaders from Ophthalmological Society of West Bengal, Dr. Pushpita Sahu Madam and Dr. Shubhashish Nag Sir. We also are very happy to have with us Dr. Saurav Sinha Sir, the chairperson for the case presentation today, and senior leaders and ophthalmologists from West Bengal. We have Dr. Rupak Roy Sir, Dr. Rupak Kanti Bishwas Sir, Dr. Siddharth Ghosh Sir. Last but not the least, thank you and welcome Dr. Digvijay Sir and Dr. Divakant and the other members of Executive Committee of the Young Ophthalmological Society of India. A special and a warm welcome to my friends and colleagues joining our program through the YouTube Live. It's an honor to have all of you for the installation of the West Bengal chapter of the Young Ophthalmologists of India. The installation program will be followed by words of encouragement by the President and the Secretary, both from the IOS and the OSWB. Dr. Sinha and Dr. Namrata Sharma will also be addressing us. With this, I would like Dr. Siddharth Bose, the Secretary of the West Bengal Society, Young Ophthalmologist Forum, to share our journey so far. Siddharth, over to you.
Thank you, Dr. Vedant. I hope everyone can see my screen. So, good evening, respected seniors and dear colleagues. We all welcome you to the installation of the West Bengal State Chapter of YOSI in collaboration with our Ophthalmic Society of West Bengal. We drew our inspiration from the YOSI, the brilliant work that is being done by YOSI on all their various platforms. It is really breathtaking to see.
Your screen is not. Your screen is not moving, Siddharth.
It is moving on my laptop. Can you guys see it?
It is fixed on the first
sharing was
screen.
paused. I'm so sorry. I'm so sorry. It is somehow paused. I'll share it again. Is it moving now?
You can continue, Siddharth, but it's not moving.
Siddharth, are you moving the bottom button at the left side? There's an arrow bottom button left side. Share your screen now, PowerPoint, and don't move it from your laptop. Move it from the screen. Share screen.
Yes, sir. Yes, ma'am. I'll just do it. I don't know why it's happening like this.
Sometimes it doesn't move from the computer, but it moves from there.
Can you see?
Yeah, we can.
This is visible, yeah. Try the PowerPoint now.
I'll not turn it into full screen. I think this will be better.
Just
Yeah,
close,
that's
close
Okay.
the slide design. That close slide design on the right side.
Okay. Just
Okay.
yes. Okay. So we drew our inspiration from the brilliant work that the central YOSI body is doing we have been following them on Facebook and various platforms for quite a long time. And so we started off as a WhatsApp group. And in a matter of few days, we reached around 225 participants, which was overwhelming. So we decided to form a small core group so that we can handle all the internal affairs. And for some expert advice, we had a telephonic conversation with Divakant sir. And then we held our first core group meeting through which we decided to be a state chapter of Central YOSI. Now, the activities that we have planned in the state chapter are the annual state chapter meeting, in which we can have instruction courses, video paper presentations, academic and non-academic debates, quiz competitions, separate specialty CMEs, PG teaching sessions, surgical training sessions, clinical skill workshop. We have even planned to have our separate newsletter, which Dr. Devanjan will be sharing at the end of the academic session. And also we'll be having our core committee meetings once a month. Let me take this opportunity to introduce you to our own Bengal YOSI Facebook page, where we will be posting all our updates and events. Now, we wish to collaborate with OSWB from here on. All our activities will be under the OSWB and Bengal YOSI banner. We can have the esteemed OSWB members as judges and panelists for various sessions. We have an excellent faculty at OSWB who are going to be invited as esteemed speakers for the teaching sessions. And we wish to merge our annual midterm meetings with OSWB and help them out in the various PG teachings and free paper competitions. This is the end of my introduction. I hereby call upon the Honorable President of YOSI, Dr. Digvijay Singh, and Honorable General Secretary of YOSI, Dr. Divakant Mishra, to lay the foundation of the West Bengal state chapters. Dr. Digvijay sir is a consultant pediatric ophthalmologist in Gurgaon, and Dr. Divakant sir is a vitreoretinal consultant in Lucknow. Gentlemen, kindly do the honors. I'll stop my screen share.
Can we hear from Dr. Digvijay sir first?
It's indeed a pleasure, when we heard that West Bengal, all of you wanted to have a state chapter of YOSI. It has been one of the states which has given so many ophthalmologists, so many top-ranked ophthalmologists to the country and leaders, and it's a state which has done a lot. And I think the young ophthalmologists there obviously, deserve to take that banner even higher. And so therefore we were very happy. From the central YOSI side, we'll be providing you all the support that we can. It's also an honor to be doing this installation amongst all the seniors, Dr. Pushpita ma'am, Dr. Subhashish sir, Dr. Namrata ma'am, Dr. Rajesh Sinha sir. And, in their presence, it's always a good blessing to start with the seniors on fray. And, we have to take the seniors along with us. And I know that they'll be our mentors. They always have been, and I'm sure the same in West Bengal for all of you. And I do wish all of you the best, to Siddharth, to Vedang and your entire team. And as particularly Vedang has a important job to lead it, and setting it up and running it for the first time is always always a difficult task. And I know that but I know you'll do it. And it's all the very best from our side. And Devakant would share a bit about what YOSI is, and how the state chapters come about to be, and what we'll help you guys with. Devakant, over to you.
Sure. Thank you so much, sir. Yes. Okay. So are my slides visible?
Yeah. Yes, Devakant.
Okay. Thank you so much. So before we move on to the actual installation, and I'm really happy to see all our leaders from AIOS and OSW here, and it's so wonderful to see their support. So before we move on, I'll just tell you a little bit, and I'll rush through this presentation. So a lot of you might have joined here, you might not know about YOSI much. So a little bit on that. So it all started in 2014 with, which was, the team was led by Dr. Tarun Arora, Dr. Vijay, Dr. Digvijay was also in the team at that time. And it became as a registered society then. And initially we started more as with an online presence where we started connecting young ophthalmologists on various social media handles that were popular at that time. And slowly we realized that there are three things that we need to focus on. First is generating platform for the young ophthalmologists, creating content which is relevant to them and hopefully by them as well, and identifying issues that they are facing and trying to escalate them to our seniors, to AIOS and other bodies as well. So this is the present team. We have 7 office bearers and 20 executive members with us. So initially, the first project that was started was Yo Times. It was extremely well received, and we are still continuing the publication of these magazines, a journal of sorts, which gives all young ophthalmologists a platform to not only share their cases and interesting clinical scenarios, but to also write about the experiences and other things which are usually not covered in traditional journals. Coming to the physical meeting, we had the first meeting in 2015, and like Dr. Rajesh sir and Dr. Namrata ma'am are here today, they were there at that time as well. So their support is continuing, and with their support, we had our first annual meeting of sorts in 2018, which was called as AIOS YOSI Forum, and it was an international meeting where we invited colleagues from our international YO societies, and we followed it up in 2019 as well. We are still contemplating how to do it this year, and hopefully we'll have some form of annual event this year as well. Coming to state activities, OSWB has been really supportive. Professor Nag and all the leaders of OSWB have been really supportive. And in 2018 and 2019, we did some really nice sessions and which were well attended and appreciated. Similarly, we have been doing sessions in all the state chapters, states society meetings, and they've been very gracious in giving us that platform. Similarly, again, with support from our seniors, especially Dr. Namrata Sharma, ma'am, we had the Yo Pavilion at AIOS, and it was the first time. See, a lot of international bodies were having dedicated areas for young ophthalmologists, but somehow AIOC didn't have that. But from the past 2 years, we have been having this AIOS YOSI Pavilion, and it has been really popular and it's picking up. So we were really looking forward to another wonderful event this year, but let's see next year, but let's see how things turn out. So we had some really nice sessions which were well attended and really appreciated. Similarly, all the national bodies have been very supportive, and we have had YOSI sessions in hopefully most of them now. So then we have this annual writing competition. Dr. Natarajan was the force behind it, and it's still continuing. We'll be announcing the details for this year's writing competition as well. Coming to our international collaborations, we have tried to collaborate with all the possible YO societies from around the world. And not only we have gained and learned from them, we have tried and we have to inspire them as well. So WOC and ICO invited YOSI to conduct the young ophthalmologist session this year, and was really well attended and appreciated. So we've been learning with the various YO societies from around the world, and the new ones like the Jordanian and the South African and the Moroccan society. We have all helped them to create these YO societies. And similarly, we are helping in forming of a Asia Pacific YO wing as well. So, and recently we got affiliated to ICO as well. So we are the first YO body that is affiliated to ICO. The other platforms like YouTube, Dr. Karan is the editor for that, has been doing pretty well. One of his videos has reached almost 30,000 views, and a lot of international young ophthalmologists are connecting through these videos. Dr. Avnish has been handling the Yo flash notes, and it has been doing pretty well. We started last year, the YOSI fellowship helped us, and more than 200 young ophthalmologists have really have been helped through this initiative. To appreciate and to encourage young ophthalmologists, we started a few awards. Last year, we started the Yo Young Ophthalmologist Award. And similarly, the best flash notes and YouTube videos were also awarded. Coming down now, this is the age of webinars, and we have tried to keep up with that. And several very successful webinars have been conducted. And the last one, which had support from the whole of the AIOC Governing Council and the heads of the most prestigious institutes. So over this 3-hour session, all the seniors sat patiently and listened to all the problems of the young ophthalmologists. We hope we can have these sessions at the state level also. And we have started some recurrent meetings like the Surfing the Anterior Segment and Late Night Retina, which are becoming really popular. And we discuss some challenging cases that young ophthalmologists face in their daily practice. So inspired by the job portal that AIOS is successfully managing since a lot of years, we have started the YOSI job portal. So the only difference being that we'll be focusing on the jobs that are just for young ophthalmologists, people who are fresh pass outs and with less experience. So we'll be so now a lot of almost 4 or 5 people have found jobs or at least job interviews because of these. Recently, we have started the residence network where we have connected tried to connect almost 800 residents to this network. And we are conducting various small workshops on simple topics which they find challenging, and sessions where they can easily ask their queries and get their doubts solved. Similarly, we have started the YES series, which is the YOSI examination simulator series, where we invite faculties from various parts of India to take an online viva of sorts, so that gives them that experience of an exam. We started the YO slides, which is like a PowerPoint presentation and keynote presentations, but these will be reviewed by a group of experts before they are put on the website. We are again collaborating with the Korean Ophthalmic Society, and we are helping them in having their first YO session. And they have invited all YOSI members to be part of it, and they'll be even giving an award of $200 for the best presentation. So I request all the members from West Bengal to participate in this competition. Soon we'll be having a monthly newsletter, a mentor-mentee program, and we are working to generate funds for research grants and travel grants. AIS has already declared travel grants, so I'm sure that will help young ophthalmologists a lot. Now coming to, so we are doing a lot of activities at the national level, but we were finding it hard to really work on the state level. So we thought we'll have state chapters. So the process is simple of forming the state chapter, where any state with over 20 members, minimum 20 members, can apply for this membership. And when we receive this application, we send out a notification to all the members that such team has sent us an application. And then if there are no objections, we go ahead and form the team for that. So now coming to the main event, that is the installation of the West Bengal chapter. So with Dr. Digvijay, are you there? Yeah,
Yes.
I would like to propose the installation of the West Bengal YOSI state chapter.
Absolutely, Devakant. I think with the blessings of our seniors, mentors from OSWB, from the AIOS, I think go ahead, we should install the chapter, and we're delighted to do the same.
Sure. So the first and the most important thing is the young leaders who will be taking care of this initiative. So the chapter will be chaired by Dr. Vedang Shah. I'll briefly introduce all the members. So all the state members can reach out to them if we need, and all national members, office bearers and executive members are always there to help them. But so Dr. Vedang Shah is working as a vitreoretina consultant at the Shri Netra Eye Foundation, Kolkata. He is also an executive member of EOC, and now he'll be the chairman of the West Bengal state chapter. He's been trained completely from Arvind Eye Hospital, Madurai. The secretary will be Dr. Siddharth Bose, and he is a comprehensive ophthalmologist and practices at Hooghly, West Bengal. And then we have Dr. Shibashish Das, who will be the treasurer, and he is a consultant at the Shankara Jyoti Eye Institute, and he specializes in cataract, refractive, and medical retina. Next, we have Dr. Aditya Pradhan, who will be taking care of the academic activities, and he's a consultant in cornea and cataract at Disha Eye Hospital. And then we have Dr. Jyoti, Mitra. She'll also be taking care of the academic activities, and she's a consultant of cataract and cornea and refractive at Premvada Birla Arvind Eye Hospital, Kolkata. Then we have some executive members as well. So Dr. Sneha Patra, she is an associate consultant at BBI Hospital, Kolkata. She specializes in phaco, refractive, and medical retina. Then we have Dr. Sagnik Suryadas. He is a cornea and cataract surgeon working at Shrut Eye Hospital. Then we have Dr. Prachi Subedar. She is a pediatric and neuro-ophthalmology consultant at Nemesis Eye Center in Kolkata. And then we have Dr. Dipanjan, who is a consultant of cataract, medical retina, and ROP at Disha Hospital. And then Dr. Saurav Bose is a comprehensive ophthalmologist at Nayan Jyoti Eye Center in Kolkata. So this will be the team that will be taking care of this. And over to you, Dr. Vedant, for the rest of the proceedings.
Thank you, Dr. Digvijay and Dr. Devakant. We are now official, and with the blessings of our senior leaders from All India Ophthalmological Society and from OSWB, I would now take their permission and start the program. First of all, I would request the president of OSWB, Dr. Pushpita Sahu ma'am, to say some words of encouragement.
Thank you very much, Vedant. It is indeed a pleasure and an honor for me to attend this webinar this evening. This is the installation ceremony of the West Bengal chapter of Young Ophthalmologists Society of India. You have already made a mark for yourself, and you are a name to reckon with. And I sincerely hope, and I'm sure, you will reach greater and greater heights. I am actually bereft of speech at the moment. I never expected this achievement in 6 years. And not only that, you are going about it in such a planned way, which our generation wouldn't even think of. So your approach is so logical, so well planned, you are bound to rise high. Okay. Now, COVID-19 has really, devastated our life, but human beings are very adaptable and they also have a very short memory. So very soon we are adopting the new normal. We have adopted the new normal, and very soon we'll forget the normal that was there 8 to 10 months back. But that is the story of survival, and we are all great survivors. Now, COVID-19 is not all bad, actually. There are certain good fallouts. Number one is we have taken a step back to look at ourselves and the universe. Bonding between the family members has increased. We have discovered new talents. We have improved our skills and what were our hobbies. And above all, these webinars. Now, these are webinars are astounding. Due to this, we have managed to attend academics all over the world. And we have managed to listen to the masters. And it has made it possible for me to attend the webinar this evening, being miles away. Ajoy, am I audible? Actually, I can't. Something has gone wrong, eh?
Yeah,
you are audible. You are audible. You are very
Something
audible.
has happened there. Okay, all right. Now, so basically, I've been practicing ophthalmology for more than 40 years. And I have seen quite a bit of changes. The youngsters today are more confident, more mature, more aware, more focused. They plan their career very well. They have to do that because it's a very competitive world. And they are bound to succeed. Now, basically, what you have shown just now is really amazing, what you've achieved. I can't get over it. And technology has improved in leaps and bounds. There are good machines which are showing us tissues and structures which we've never seen before. So this has fine-tuned the diagnosis, perhaps in some cases at the expense of a clinical acumen. Another thing I would like to remind you, because you're going to go far ahead and you are our futures, our bright stars, is that compassion and humanity is an integral part of our profession. However adverse situations we face, however brick and bats we have to face, this is what makes us unique. And I'm sure all of you are going to make good doctors, but I sincerely hope that you retain your uniqueness amongst all this and become great doctors. All my blessings, all the best to all of you. Thank you.
Thank you, Pushpita ma'am, for such kind words and your blessings. I would also like to take this opportunity to welcome Chairman Scientific Committee, Dr. Patho Bishwas sir, who has joined here with us. Thank you, sir, for joining.
Thank you very much, Vedang. Thank you for giving me this opportunity to be with you. It's a wonderful moment for all of us.
Thank you, sir. With this, I would now request the Honorary Secretary of OSWE, Dr. Subhashish Nag sir, to share a few words.
Thank you. Thank you, Vedang. Hi there, everyone. Respected leaders from AIOS, our President, OSWB, leaders of YOSI, and now the official West Bengal chapter of YOSI, and all the attendees today. A very good evening to you all. It is indeed a very memorable day. Today is because the young ophthalmologists of our state have come together to launch the West Bengal chapter of YOSI. And for me, it is a proud privilege to be part of this momentous occasion, because it is not a cliche. All real journeys start with a single small step, and you have taken that small step today. Congratulations. I'm here to bless this grand effort of you all who have made this possible. I've come across a few names who worked hard with us also. Dr. Vedang Shah, Dr. Siddharth Bose, Dr. Shivashish Das, and there must be a host of others. I saw a few names today. Thank you, everybody, and congratulations once again. But remember, with recognitions come great responsibilities, and coming together in an association is a commitment. Yes, a commitment to live up to those responsibilities, which I'm sure you will. I've got a small issue, as Devakant was sharing, the third point, issues. I think this is a year where the young who are the residents, who are doing their PGs, who are doing their fellowships, they are missing out on some aspects of their training. I think YOSI should take this up with us and the authorities together, so that the young ophthalmologists of us have a good training, which is so very important for their future and careers. And the good thing about YOSI is that they're always in sync with us seniors. We have seen that in AIOS and in OSWB. We have worked together for the last 3 years that I have been the secretary. We had the YOSI debate, YOSI pavilion, YOSI speakers, and so on. And I can assure you all in YOSI West Bengal that you will always have the support of our mentors. The seniors will be there guiding you. They will show you the way. They will share the tricks of the trade, even if you don't need it and whatnot. Not that you'll always need it. You all are self-sufficient. You have the support of your parent body, YOSI, and we all have the big daddy of ours, AIOS. But as you will realize that one always needs the local support where we all practice, where we stay, and that is where we will step in. So please keep in touch that you are. Be a part of OSWB. Take off in style. I only wish you fly high and high, but never lose contact with the land. I wish you all success in all your endeavors. Also, academic and professional success. Stay happy, stay blessed. Thanking you once again. I wish I could go yo again. Thank you.
Thank you so much. Thank you so much, Shubhasish sir, for all your support and belief in us. We really appreciate it. I would now request the Honorary Secretary of AIOS, Dr. Namrata Sharma ma'am, to kindly say a few words.
Mm, it's a privilege and a pleasure to be here amongst young ophthalmologists once again. We always look for opportunities and seek opportunities with you all because we like to feel young. And from the activities which Devakant has already mentioned, YOSI is already happening and is vibrant. And it's 6 years old and 6 state chapters already. And extremely importantly, I think, is that it is also taking the onus and responsibility of starting the yo chapters in other international countries also. I think that is something which we all need to learn from them. They are helping their counterparts in other countries to open the yo chapters, which even at the level of AIOS, we probably are not doing. We are just affiliating or signing MOUs, but that's a great service to the international society. So again, like always, it is a very nice feeling to be here. I would particularly like to acknowledge the OSWB because you are lucky. Not all state societies are so forthcoming. Dr. Pushpita ma'am, Dr. Subhashish Nag, and all the office bearers and the representatives of OSWB have been so cooperative and have been helping you, because I know of states where people are not so forthcoming for the young ophthalmologists. But I think I would like to congratulate again all of you. I would like to congratulate the president of OSWB, recently installed Dr. Vedang Shah, Secretary Siddharth Bose, uh, Shivashish Das, Aditya Pradhan. Nice to see that there's a lot of female representation also. Joyati Mitra, and Sneha, Prachi, Nandini, who are all our young friends, whom we meet in all the conferences. Sagnik, Debanjan, and Saurabh Bose. One thing that I would like to say that YOSI did virtual AIOS YOSI, this concept of a virtual platform. I think when we did the first AIOS YOSI forum, even then I think we took it from you only. You invited people from Singapore and from other Asia Pacific countries who were on a virtual platform. So you started it all with international speakers, and again you have another feather in your cap because you're doing a first virtual opening of a state chapter of any society, which probably no society has done up till now. So it is good to see this. We are always there, like Dr. Subhashish Nag sir also said, and Madam also said, we are always there behind you. And I'm sure you have a long way to go, and I'm sure you will go there very fast. What we achieve in 20 years, you achieve in 2 years. So, so I think with this rapid pace, you will be there, and next we'll be asking you, what should we do? Please tell us. So it's going to be like that. So thank you again, once again, for having us. And like I always said, that AIOS leadership, Dr. Partha Bishwas is here, Chairman Scientific Committee. Rajesh Sinha is there, Treasurer AIOS, and I know that he's played an extremely important role in the conception of the YOSI concept, which actually started in his own room in, with Tarun Arora, Vijay Sharma, and Digvijay Singh. So I think he's going to throw some light on that. So AIOS leadership is always there with you, and you just need to do things the way you are doing, and we are always there. Thank you so much for having me here. It is always, like I said, a pleasure and a privilege. Digvijay Singh has been one of the students from RP Center, very bright, and he's very modest, doesn't say much, but he's a man of actions, and so is Devakant. And all of you for that matter. I've seen you at all the various platforms. I can't see Sonal Kalia here in my frame, but I'm sure she's there, the vice president of YOSI again, who's very vibrant. Karan, I saw, and I saw so many of you here, and I'm sure you'll go a long way. So thank you once again, and many congratulations to the OSWB chapter.
Thank you, Namrata ma'am, for such encouraging words. You have been the guiding star with all the senior members, and we all appreciate your guidance and efforts that you have taken. We have Dr. Rajesh Sinha sir, who will be sharing an exciting news and an exciting proposal to all of us. But before that, we'll have our guest lecture for today's evening. I would now take the opportunity to introduce to you Dr. Rupak Roy sir. Dr. Rupak Roy sir did his MS in ophthalmology with gold medal from the RIO Kolkata. He subsequently joined the Shankara Netralaya, Chennai as a long-term vitreoretina fellow. Upon completion of his fellowship, sir joined as a consultant in Shankara Netralaya in Chennai and then in Kolkata. He was also the deputy director of academics at the Shankara Netralaya, Kolkata. He has published more than 100 articles in peer-reviewed journals and has keen interest in complex vitreoretinal surgeries and retinal imaging. He's currently working as a senior consultant in the BBI Foundation, Kolkata. I think we all know Rupak Roy sir and his achievements. Over to you, Rupak Roy sir, for the guest lecture for today.
Thank you, Vedang. I'll just share my screen. Host. I have this, Vedang, I have this notification, this host disabled participant screen sharing. Can you just check?
Yeah, sir, I will.
So you can do it now, please. I have disabled it. And before sir sets up his presentation, I just forgot to introduce Dr. Nandini officially. So I'll just do that quickly. So she's working as a cataract, refractive and medical retina consultant at Amri BBI Foundation, Lansdowne Eye Care and Calcutta Lions Nathan Nikevan. So she has been our link with the OSW, and she had conducted the quiz and the debate sessions with us on behalf of YOSI. So those are really wonderful sessions. Thank you, Dr. Nandini, for that. So please, with your presentation.
Thank you, Dr. Vedang, for your nice introduction. Good evening to respected seniors from AIOS, YOSI members, and all my friends. It's a privilege to give a talk on this great occasion of the installation of the YOSI West Bengal chapter. As Dr. Namrata madam rightly said, this is a great opportunity for all the young ophthalmologists, and they will really travel the distance. So I'll start my presentation. It is on management of cataract with diabetes. So cataract surgery, so the crux of the topic is cataract surgery in a patient with the diabetic retinopathy. So what are the challenges? The primary challenges are retinopathy progression of maculopathy, and there are always increased risks of complications. What is the rationale? Diabetes subjects have an overall increased level of inflammatory activity in comparison to non-diabetic subjects, and any surgical trauma causes release of prostaglandins and other cytokines, can affect the already compromised blood-retinal barrier of patients with diabetes with a magnitude that increases with the increasing severity of diabetic retinopathy and maculopathy. So what are the broad guidelines of managing a coexistent case of a cataract with a retinopathy? Is to treat the macular edema first. If it is a patient of PDR, always try to complete the pan-retinal photocoagulation first and achieve a good systemic control before you go on for your cataract surgery. Now coming to risk stratification, we have seen that patients with macular edema after cataract surgery in eyes with preoperative, so if we compare eyes in which there were macular edema before cataract surgery to eyes which did not have macular edema, the chances of progression of macular edema is high at a risk of around 10%. Also, there is an enhanced risk of pseudophakic macular edema to a level of around 4 to 6% in otherwise uncomplicated diabetic eyes. So now coming to the crux of core topic, that treating macular edema with significant cataract. OCT versus photography for diagnosis of DME, it is always encouraged that you always do, the Cochrane review conclusively recommended that SD OCT as the most sensitive tool to detect macular edema. So it is always recommended you do a baseline OCT for patients with diabetic retinopathy before you embark on a cataract surgery. Because sometimes on clinical examinations, you can tend to miss subtle edemas which OCT can pick up for you. Now we'll go to certain scenarios. This first scenario will be a patient with a cataract with no retinopathy. The recommendation of these patients are you use topical nepafenac for 60 days after cataract surgery, that you continue to use nepafenac after an uncomplicated cataract surgery. No other intervention is required. Patient with a cataract plus retinopathy but no diabetic macular edema or center involving macular edema. This patient needs prophylactic nepafenac, which has to be started at least 7 days prior to the surgery, and always do an OCT 1 month after the surgery to assess the macular status, whether the patient is developing macular edema or not post cataract surgery. Scenario 3 is the real challenge, that is cataract with a center involving DME, treatment naive, that is the patient has not got any treatment elsewhere. This kind of patients need some sort of adjunctive pharmacotherapy treatment in the form of injection. They can be given preoperative, combined during cataract surgery, or 2 weeks after cataract surgery. So some people prefer to give injections, make the macula dry, then do cataract surgery. But if the cataract is significant, it is advisable to do the injections or the pharmacotherapy along with cataract surgery. Now, among all agents, which agent to choose? DRCR network has really given us a path in that direction. Its recommendation is cataract surgery, and for any treatment naive macular edema, anti-VEGF agent is the agent of choice. So there are many options now: ranibizumab, bevacizumab, and aflibercept. The question is which one to choose. If one has to choose one, probably the first choice option should go towards a ranibizumab. The protocol T, which came out of the DRCR, has shown us if the patient has good vision, there is really no difference between the action of these 3 molecules. But if the patient has a poor vision and a thicker macula, probably aflibercept works better. Scenario 4 is a patient with a cataract who is not a treatment naive. He has received treatment prior and is in a refractive state or a refractory DME. There are many options that you can choose in these patients. You can consider an anti-VEGF switch. You can combine cataract surgery with a different anti-VEGF, or you can combine cataract surgery with triamcinolone acetonide or a dexamethasone implant or dex implant called Ozurdex. Out of these all options, probably a combination with a dex implant suits the situation better. So it is ideal to go for a combination of a cataract surgery with a Ozurdex implant. Now, multiple case reports have really shown the efficacy of triamcinolone and Ozurdex implant in diabetic macular edemas. Ozurdex is preferred because it has got a longer duration of action, it has got less IOP spikes, and more importantly, it can be given to patients with glaucoma, more specifically stable glaucoma on a single anti-glaucoma medication. However, use with caution if the patient is on multiple AGM. But if the patient is a patient of stable glaucoma with a single AGM, Ozurdex can be easily used. Scenario 5 is a cataract with a proliferative diabetic retinopathy where there is no traction on ultrasonography and there is not enough view which allows you to do laser. In this patient, you can consider cataract surgery with an anti-VEGF agent like ranibizumab and follow the patient with the PRP as soon as the view permits. Scenario 6 is a cataract surgery with an ischemic maculopathy. You can have a clinical picture like this. There is a wide ischemia. The treatment of choice for this kind of scenario will be a cataract surgery with intravitreal steroids. Again, when you choose intravitreal steroids, probably the best choice would be an dex implant. But however, if the patient is not affording, you can very well choose an intravitreal triamcinolone acetonide, which is much cheaper. Well, saying this, if the patient has macular ischemia, anti-VEGF agents are not an absolute contraindication. You can also try anti-VEGF agents in patients with diabetic macular edema with macular ischemia. But however, steroid should be the first line of therapy. Scenario 7 is a patient with cataract with a vitreomacular traction like this. These patients are not to be managed pharmacotherapeutically. They need surgeries. Vitrectomy is the preferred surgery along with the cataract surgery. So is there any role of laser in this current scenario of or current era of anti-VEGF? There is a role of laser. Laser to areas of focal leakages can be done post-injection and cercinets before cataract surgery or as soon as the view permits after the surgery. Rescue macular laser can be attempted in non-responders to intravitreal pharmacotherapy. Rescue macular laser in the form of a modified grade therapy. Now coming to another important entity, most often there is a common clinical confusion in a patient with a diabetes after cataract surgery developing a macular edema, whether the patient has a diabetic macular edema or a pseudophakic macular edema. So this is a patient, you can see there is a macular edema, there is a leakage, petaloid leakage in the center, and OCT shows macular edema. Most interestingly, what you find in this case, the disc is hot, there is disc staining. So this is a case of pseudophakic macular edema where you will find features of macular edema along with disc staining. On the contrary, this is a patient with a diabetic macular edema where you find the disc is silent. There is a NV which is leaking just below the disc. So this is a diabetic CME. So in a nutshell, the key point to differentiate between a diabetic macular edema and a pseudophakic macular edema will be the disc staining, which we should look for whenever we have a confusion of treatment of this entity. Now, pseudophakic CME responds good to nepafenac. You should ideally consider nepafenac for at least 6 weeks to 2 months. If there is no response even after nepafenac, you can try intravitreal steroids. There is limited role of anti-VEGF in treatment of pseudophakic CME. Briefly, there are many expert cataract surgeons here. I am not a cataract surgeon. There are such and preferred IOL choices like an acrylic hydrophobic, a large capsular axis, square edges of the IOL, and in the black implantation is preferred modality of treatment in a cataract surgery. So thank you very much for your kind attention. Thank you very much again for this opportunity to speak in this installation program of YOSI.
Thank you, Rupak Roy, sir. It was wonderful to see all the case scenarios and as to how to proceed with them. Dr. Saurav Sinha, sir, as the chairman and as the senior retina surgeon from Kolkata, I would request you to say some few words, or if you want to add on to some points. Dr. Sir, Saurav sir.
Yeah, is Dr. Divakant there? Dr. Mishra?
Yeah, Dr. Divakant is there, sir.
Divakant,
Sir.
Yeah, when we were in MBBS, we used to get grace marks to pass the MBBS. So YOSI ka cutoff is ke baad kuch grace marks hota hai kya? But people like us, the amount of work you guys are doing, maybe I'm thinking I'll join you guys only. Great work, really.
You can definitely join, sir. I'll send you the membership links.
Amazing. I'm really impressed. Good job. And I also have a complaint against Vedang. I have never been a chairperson of a session, and I know why. Iska koi kaam hota nahi hai. Chairperson is the most useless thing. I wish I was presenting. You'll have made me feel really old today. So I have to refuse next time being a chairperson. I think a panelist is a much better thing to do. Moderators are better people to take up. I suddenly feel extremely old today. Rupak Roy, I think, did a great job. He's my colleague and he does a fantastic thing. I'll make just one point from the pure real world scenario and forget the studies and the TDRS and all those things. Somehow I feel that you need to drive home the patients who have diabetic macular edema, which is visible to you on examination. You must take a color photo, even the OCT photo is very bad, and bang the point into the patient before doing cataract surgery or while doing cataract surgery that you are not going to get normal vision back, and treat or at least offer some treatment before or during the cataract surgery. The 2 weeks after cataract surgery is sometimes you lose the patient at that time, the confidence of the patient at that time. So possibly my
I think cannot some network issues. In the meantime, Rupak sir, there's a question, and the question is, what is the treatment of CME which has initially responded to Ozurdex but has reoccurred? So Dr. Divya is asking that.
Yeah, so this is a good question. This is a very common clinical scenario that we face. The patient. So now we have to understand that diabetic eye disease is a lifelong disease. It's not like a BRVO. There is a in BRVO what happens? There is a one-time surge of anti-VEGF, and slowly the VEGF surge goes away. So BRVO tends to stabilize over a period of 2 to 3 years. But diabetic eye disease is a lifelong disease, so it is very common to patients to recur. So if the patient has initially responded to Ozurdex, I would really like to repeat the Ozurdex again. But it is a different scenario if the patient did not respond to Ozurdex at all. Then we would like to revisit our diagnosis, probably do a fundus fluorescein angiography to see whether, and I assume Ozurdex has been given after a trial of anti-VEGF agents. So there is no point of going back from Ozurdex to anti-VEGF agents. So if the patient does not at all respond to Ozurdex, then we would like to revisit our diagnosis, look for macular ischemia, look for leaking MAs, consider laser. But if the patient has responded and then again recurred, this is a very common scenario. This can happen in diabetes because there is a constant surge of anti-VEGF. So we'd like to go for a repeat Ozurdex injection.
Thank you, sir. Saurav sir, sorry, we got interrupted by the lapse of the connection. Please continue.
I think my connection is still unstable. I like to stop with that. The point. Am I audible now?
Yes, sir. Absolutely loud and clear, sir. Please go ahead.
Okay. Just that one point that in real world scenario, it's always better to drive home the point in diabetics to show a color photo to them and impress and treat before the cataract surgery or along with the cataract surgery. Waiting to treat 2 weeks after the cataract surgery, which is an option possible scientifically, but real world scenario practicing that after the cataract surgery, little difficult convince the patient to pay money and get treatment done again. So whatever treatment to do is either do it before or along with the cataract surgery, at least start the treatment. It's not the end of the treatment, but at least start it there itself. Otherwise, patient goes home thinking, cataract karwa liya, things are going to get better. And he said something also, but cataract karwa rahe, because it's difficult to drive in the point who's not had any treatment before. Patient having had multiple injections, lasers before is a different story altogether. I had to talk about a naive, plain cataract with some CSME. Please treat before you do cataract surgery along with cataract surgery. Thank you.
Thank you, sir, for the words of wisdom. I think Dr. Maiti, sir, wants to say something.
Yeah, Rupak, excellent presentation. You have covered almost all scenarios. I would just ask you a question, like at what point you will go for this ILM peeling in a recalcitrant DME? And when do you do this ILM peeling for a DME?
To be very honest, this is a surgery which I do not do very commonly because experiences have shown that with ILM peeling, there is increase in the perfusion, but the visual gain is not much.
Anatomically better, yeah.
An anatomical gain is there, but visual gain is not much. So, but I think when all sorts of intervention fails, like you have tried anti-VEGF agents, you have tried Ozurdex, and still the edema is persistent, then probably if you have an inclination, you can go for that surgery. But again, that surgery is not very rewarding, I would say. Just a simple, just a simple ILM peeling where there is no macular traction. I believe if there is a macular traction, obviously you have to go for surgery. But just for persistent edema, ILM peeling, there are people who do it, but I am not a great advocate of that.
I think that should be the last thing we should go ahead with.
Thank you so much. There are some questions. We'll take them after the case presentation. Before that, I would now invite the Chairman Scientific Committee, Dr. Partho Biswas sir, to say a few words.
Thank you very much, Vedang, for giving a very personal invitation to this wonderful occasion of the YOSI chapter inauguration at West Bengal. And it's really a proud moment. And Pushpita Madam and Subhashish Da has said everything that is so appropriate, so inspiring, so important. With this, I have just 2 or 3 things to share with you. 6 years old YOSI. Devakant, is that right?
That's right, sir.
LDP is something that I know for the last 6 years. And if you ask me something, that what makes these leaders of YOSI so vibrant, I'm going to tell you there's a common factor. Devakant, Karan, Vedang, Avnish, Sneha, there is one common factor. They are all LDP graduates. And, you know, we seniors have this habit of, you know, pulling up our muscles and say that we are also a part of this vibrant group. Yes, it is important. And I think at LDP in the ARC platform, the AIOS definitely gives certain lessons of life, which are so important for us not only to be ophthalmologists, but to go beyond ophthalmology. Because it's that beyond ophthalmology that we have never learned in those so many years of medical science, the post-graduation and everything. और फिर तो ठोकर खा खा करके leadership सीखना पड़ता है. So if there is something of that leadership platform learning, it is a big thing for each one of us in our own small ways. We can actually understand what this teamwork is, how to go ahead, and how to forge ahead. The leaders of tomorrow is the YOSI of today. So if the YOSI of today are going to be leaders of tomorrow, that responsibility has to be ingrained today. And whatever has been ingrained today and where you have already reached in these 6 years, absolutely, the sky is going to be the limit. There is nothing unsaid about this. And as Subhashish Da in his last few words was trying to express a very beautiful couplet from Rudyard Kipling, which I remember and which is in my heart. I'm going to say this just after 1 more minute. And that is to say, we at AIOS and Namrata and Rajesh are here, and they will definitely reinstate the facts that we at AIOS value you, value your suggestions, value your intellect, value your vibrancy, and value every one individual. Therefore, you also have to help us, lead AIOC, not tomorrow, but today as well. The words of Rudyard Kipling are, and they are very beautiful words, think of the bird that soars but never roams, true to the kindred points of heaven and home. Thanks a lot. All the best, YOSI. All the best, West Bengal chapter of YOSI.
Thank you, Partha sir, so much for these words, so much for pushing us, and for so much for the words of encouragement. Thank you so much, sir. I would now request Dr. Rajesh Sinha sir, the honorary treasurer of AIOS, to say a few words and also share with us an important topic which is going to be definitely useful for all of us.
Thank you, Vedang. Very good evening to all of you. It's a momentous occasion, and I can see I'm here from 8 o'clock, and I'm hearing so many stalwarts, Pushpita ma'am, Dr. Subhashish Nag, Dr. Namrata, and of course, Dr. Partha, who is always so good when he's talking. So, I mean, wonderful things have been told about YOSI, and it takes my memory back to 2013-14 when Tarun and Vijay and Digvijay, they came to me and started discussing about this concept. And we used to work in the evening, late evening after finishing all our clinical work. So 8:30, 9 o'clock. when we used to get phone calls from home that when are you coming, then we used to leave the office. So at that time we used to discuss about all these, but honestly speaking, I had never thought that, you know, your team, the young ophthalmologist team, will take YOSI to such a level. It has really become it has reached such a level that I really feel proud of you all, that, you know, you all are you know, so nice juniors, so close. Some of you have been directly students of ours. I can see Sagnik also here, who was a very bright student of our Center. And then after that, we had repeated discussion about this. And I remember Sonal Kalia discussing with me about the YO times. And I mean, so many good discussions, so many nice features, the meetings, conferences organized by YOSI. So the memories have been extremely good. And the way you are moving really with a very brisk pace. And I mean, this is expected of you. You are the current generation or next gen, whatever you call, but you are really, you know, doing very well. So congratulations to you, and congratulations to the leaders of West Bengal chapter, especially because they have been installed today: Vedang, Siddharth, Shivashish, Aditya, Jyoti, and all the executive members. So it is a wonderful day for them and wonderful day for us. And on this wonderful occasion, I would like to make an announcement for the young ophthalmologists. I'm also the General Secretary of the Family Benefit Scheme of AIOS, that is FBS AIOS. And I would like to make an announcement that, you know, over the next, we are launching a scheme, and you can consider this day as the launching day of this scheme of FBS AIOS for the young ophthalmologists. And over the next 4 or 5 months till the 15th of January, we will have this scheme wherein the young ophthalmologist will have the opportunity to become the FBS member in 50% or even less than 50% of the admission fee. And even the yearly contribution, those who are less than 40 years will be less than 35 will be paying 50% of the yearly contribution, and less than between 35 to 40 will be doing 75% of the yearly contribution. So it is a wonderful scheme wherein I would like to invite you all to become a member so that you can secure your family. And the basic idea that came to us to launch this scheme also came from YOSI only, because your YOSI leaders like Digvijay, Devakant, Sonal, they used to tell me that something should be done because this scheme was not made for young ophthalmologists. So you have this scheme was not made keeping in mind the needs and the compulsions, the problems of young ophthalmologists. So do something for young ophthalmologists so that they get encouraged to join FBS. And that was the reason why we did it. And after, you know, making this scheme, we have discussed with the YOSI office bearers, and they'll be the first to become members of FBS. And they will, of course, make announcements to you. And but this is what I have to say. And we all should secure our families. So that way you all should think about it. It's an opportunity for you. And coming again back from this announcement, I would like to congratulate you all for doing wonderful work. Keep doing the good work and keep shining, and keep you know, making us feel proud that we are, you know, your seniors. Thank you very much.
Thank you, Rajesh sir. Excellent initiative for young ophthalmologists. Thank you for helping us, and definitely on the occasion of the installation of this West Bengal chapter, we are very happy to have you launch this family benefit scheme for the young ophthalmologists. Thank you so much, sir.
Just one point I would like to add, that you all are net savvy.
Yes.
can go to the website. So tomorrow morning you can go to the website, and from tomorrow you can start becoming a member. So the website is fbsaios.in, and you can go to the website, log into it, and go ahead.
Wonderful,
I
wonderful.
think, Dr. Rajesh sir, this is indeed a wonderful scheme, and all the effort of putting this together, a lot of the credit goes to you. And I encourage all the young ophthalmologists to become members now. At this age we don't think of possible calamities or situations where our families need support. But I think we all need to understand that, and so a scheme like this really works. So I would always encourage all the EOs to go ahead and look up this scheme and become members.
Thank you, Digvijay sir. I would request Dr. Ajay Paul sir, senior ophthalmologist from West Bengal, to say a few words, please. Sir, we cannot hear you.
Yeah. Thank you, Vedang and Siddhartha. You have done a great job starting this YOSI chapter. I think our generation, as a lot of people have said, that we were, rather laid back. We didn't plan our future, but definitely you people are so up to it with those excellent presentations that I have seen over the years in the state meet and the debates and the national forum also. Now you have gone international. Kudos to you all. I wish a bright future for all of you in the West Bengal chapter so that you shine in the national forum and the international forum. Thank you, Vedant. Thank you.
Thank you, Ajay sir, for your words of encouragement. I would now request Dr. Shivashish to introduce the chairpersons and the panelists for the case discussion for tonight.
Hello, everyone. Good evening. So it feels I'm really privileged to be speaking in front of such leaders in our field, national leaders and our inspiration from our states. So today we are introducing our state chapter of YOSI, the West Bengal state chapter. Along with that, we have some academic session also planned ahead of us. Dr. Saurabh Bose will be presenting a case presentation. So for the academic session, we have our chairperson, Dr. Saurabh Sinha sir. Dr. Saurabh Sinha sir is a senior consultant at BBI Foundation, Kolkata. He was the ex-medical director and chief at Shankar Netralaya, Kolkata. He's an eminent VR surgeon, and he takes special interest in teaching young surgeons and young doctors like us. In our panelists, we have Dr. Rupakanti Bishwas sir. Dr. Bishwas is a senior consultant at BBI Foundation, Kolkata. He's also the executive member of OSWB and chairman of the PG Education Committee of OSWB. And he's also the ex-consultant at Shankar Netralaya, Kolkata. We also have Dr. Aniruddha Maiti sir. Dr. Aniruddha Maiti is the senior consultant and the chief of VR department of Sushrutai Hospitals in Kolkata. He is also the chairman of the scientific committee of OSWB. And we also have Dr. Siddhartha Ghosh. Dr. Siddhartha Ghosh is a consultant ophthalmologist at GD Diabetic Multispecialty Hospital and Apollo Hospitals, Kolkata. He is currently the treasurer of OSWB. We have Dr. Avnish Upadhyay. Dr. Avnish Upadhyay from YOSI is a vitreoretinal consultant at IQ Super Specialty Hospitals, Gurugram, a former consultant at Sri Shankaradeva Netralaya, Guwahati. His special interest lies in imaging macular disorders. So going forward with our scientific presentation, I would request Dr. Saurabh Bose if he can start his presentation on today's topic of diabetic retina. Dr. Saurabh, are you there?
Yes. Am I audible?
Yeah, you're perfectly audible. Over to you, Dr. Saurabh.
Thank you, Dr. Shivashish. Very good evening, respected seniors and my colleagues. It is indeed an honor for me to be able to present my case in front of the stalwarts of ophthalmology. So I'll just begin. Is the slide visible?
Yes, your slides are perfectly visible. You can continue. Yeah,
thank you.
We're moving fine.
So in the installation chapter of our state from the Young Ophthalmologist Society of India, This case is regarding a 67-year-old female patient who presented to us in the clinic with the complaints of gradual onset progressive diminution of vision, which was again painless in both the eyes for the last 1 year, associated with distortion of vision in both the eyes for the last 5 months. The complaint started in the right eye, and gradually the left eye was also involved. The first ophthalmological consultation was about 4 months back, but the patient did not have any relief in her symptoms. There was no associated history of any ocular trauma, pain, redness, any appearance of floaters, flashes, any curtain fall effect. There wasn't any history of disturbed sleep or any addiction history. The patient was diagnosed as a case of type 2 diabetes mellitus about 15 years back, for which she was on chronic medication. However, there was no evidence of any other known systemic illness. When the patient presented to us, she was on oral hypoglycemic drugs, topical nepafenac drop, carboxymethyl cellulose, and she also reported to have undergone cataract surgery in both of her eyes in 2014. No documents were available though. Her father was a known diabetic. Apart from that, there was no significant history in this case. On general examination, everything seemed to be normal. On ocular examination, the best corrected visual acuity was 618 in the right eye and 624 in the left eye. On the ETDRS logMAR scale, it amounted to 0.5 and 0.6 respectively. The near vision was N18 and N24 respectively. Pupillary reactions were normal, other findings were normal, but the Amsler grid test revealed that there was gross distortion while visualizing the Amsler chart with the left eye. Slit lamp examination of the anterior segment revealed everything within normal limits, except for the fact that both of our eyes were pseudophakic. Coming to the fundus, we regularly do fundoscopy in known diabetic patients. So I just uploaded the fundus picture. In both the cases, we can see that the media was clear. The optic disc was normal with a vertical CD ratio of about 0.5, 0.6. The blood vessels per se were normal. There was associated superficial as well as deep hemorrhages in all the quadrants in both the eyes, associated with a bit of hard exudates in and around the macular area and a few cotton wool spots, more in the left eye. There was definitive macular edema as seen clinically. So we ordered certain investigations. The primary ones were the blood sugar levels, which were raised. The glycemic control of the patient was also poor, as revealed by a 7.2 value of HbA1c. The lipid profile revealed that the cholesterol level was 234, which is more than the normal. The rest of the lipid profiles were normal. The serum urea and the creatinine levels were also above normal levels, and the blood pressure was measured at our clinic, which was within normal limit. OCT macula was advised for both the eyes. In the right eye, we can see that there was definitive macular thickening along with intraretinal cystic spaces. Although the outer retinal layer was preserved, the inner retinal layer was separated, and there was fluid collection within and below the retina. So subretinal fluid collection was also present. The central retinal thickness in this case was 395.5 microns. Coming to the left eye, it was in a worse condition where there was complete disruption of the inner and the outer retinal layers at certain places. But the macula had subretinal fluid. There was definitive distortion, macular thickening once again, and the central retinal thickness in this case was 440.5. Our fundus fluorescent angiography was planned, but due to the altered urea and the creatinine levels, in the initial setting, it was not done. So from the history and the investigative point of view, we came to the following differential diagnosis. It could be a case of a diabetic macular edema, a cystoid macular edema, a hypertensive retinopathy, or a venous occlusion with macular edema, or it could be a subfoveal CNV. But there was specific and relevant history of having a diabetes mellitus type 2 for the last 15 years, having a diabetic father, then examination revealing certain characteristic diabetic changes in the fundus, and investigations supporting the facts, we came to the provisional diagnosis that it was a case of diabetic macular edema and not the other differentials. We went by the ETDRS classification, whereby the fundus could be, where the condition was classified as a case of moderate non-proliferative diabetic retinopathy with macular edema in both the eyes. The reason why moderate was this is the ETDRS classification. We see that the reason why we diagnosed it as a case of moderate, because although all the quadrants had microorganisms and exudates, cortical spots, but the criteria of 421 that differentiates the severe from the moderate, this was not followed. The number of intraretinal hemorrhages was less than 20, and venous bleeding and IRMAs or intraretinal microvascular abnormalities were definitely absent. And macular edema, and obviously it was not proliferative because no evidence of proliferation, at least clinically, was evident. And there was no vitreous hemorrhage or no neovascularization evident. Macular edema was present, and by the clinical evidence, it was CSME as well, because there was definite hard exudates within 500 microns of the center of the fovea. So the OCT features were there, and this slide is actually put up to show that according to the recent OCT classification of diabetic macular edema, it could be classified as having diffuse retinal thickening. There was cystoid macular edema, and there was subretinal fluid present. Posterior hyaloid disturbance was not present, and obviously tractional elements were absent. So although we have a number of classifications functional at present, we chose the ETDRS classification because of wide acceptability. So we started the treatment. Firstly, the glycemic levels were asked to be controlled strictly, and a physician reference along with his valuable opinion was taken, because the glycemic levels were altered and the urea creatinine levels had also to be recovered. Next, according to the OCT and the clinical picture, ranibizumab injection intravitreal was planned, 0.5 milligram per 0.05 ml in both the eyes. And 3 injections were planned at an approximate intervals of a month. Along with that, eye drop bromfenac 0.09% BD dosing was started, along with an oral antioxidants. And currently, although the patient was advised on a 3-monthly follow-up after the last injection, unfortunately, she could not turn up due to the lockdown period. So we have an OCT picture of the right and the left eye following the different injections. So in the right eye, we see that we started off with a BCV of 618 and the central retinal thickness of 395 microns. And after 3 doses of ranibizumab, the visual acuity, the best corrected one, it improved to 6.6 part, along with a CRT of 277.4 microns. Similar in the left eye, we can see that we started off as with a BCV of 624 and the accompanying CRT of 440 microns. And by the end of the 3rd dose, the patient had a 6.6 part vision along with the CRT of 279.2. Unfortunately, we also planned, as I already mentioned, an FFA along with the decision to whether or not to treat laser, but the patient could not follow up with us. So this wraps about the case. Thank you.
Thank you, Dr. Saurav, for such a wonderful presentation on this case. I would request our chairperson, Dr. Saurav Sinha sir, to have your insights about how you would have handled or about the case, how you would have handled such a case, sir.
Dr. Shivashish, thank you for the invitation. Can I just want to twist on this and make it a little bit more interesting? Can I have the panelists come on, please? Dr. Siddhartha Ghosh is there, sir?
Yeah, I am there.
Siddhartha, hi. Angiography, I'll just to make it twist and easy for everybody, because this is not a retina session. What is your take on, firstly, fitness for an angiography? It's a very dicey topic. It's got lots of twists to it. But your take, your personal practice take, you are not an institution, you do your own decision making, for where you will say no angiography for this patient. What parameters, what systemic lookout, or what quality of a patient, kind of a patient?
Yeah. First thing, to begin with, I would first congratulate YOSI West Bengal chapter and YOSI India as well. Well, if we look straight at, it's a very big step today. So I cannot stop but congratulate everyone on this occasion. Well, coming straight to the point, what should I do first? When do I really think of FFA? In this case, maybe because of the creatinines, and I'll not really think of FFA straight away. But one important thing here is looking at the lipids.
that is also important. We need to lower down the lipids because, we have seen those hard exudates pretty close to the fovea in the left eye. So once the fluid comes down, the hard exudates would just go and sit on the center of the fovea, permanently reducing the vision. In this case, maybe it did not happen so fast. Another thing is, how fast could you inject in both eyes? That is another important issue. So all these things taken into consideration. And as Dr. Saurabh Sinha has asked, like, what would you do fast? We would actually treat the patient on the systemic parameters first. We want to reduce everything adequately. And yes, anti-VEGFs are the treatment for choice. But before that, this OCT itself is good enough for guiding and prognosticating and following up these cases. Well, if these patients who do not respond well to anti-VEGFs, and then we switch to some other drugs, maybe more anti-VEGFs or maybe steroids, and then even then if they are refractory, you go for a FFA, and even by that time, if creatinine hasn't come down, we have to think over. And another important issue here is, the hemoglobin of the patient. Hemoglobin is also important because many times we miss out on that. There's a lot of edema. We have seen there is a lot of edema. And also differentiating the pseudophakic edema and diabetic edema here. We have seen a lot of subretinal fluid. So anyways, these are the ways to go, and he has managed it pretty well, extremely well. But systemic control is number one, and looking at the lipids and controlling them is very important.
Thank you, Dr. Siddhartha. There is a statement come question from Dr. Shagnik Sen in the chat box, and it's a long thing. He talks about, if the patient has nephropathy, why do you want to do a FFA in the first place, and recent studies regarding anti-VEGFs in nephropathy patients. So I'll ask Anuruddha that. Anuruddha, do you, looking at the nephropathy nowadays, last 3 to 6 months, a year or so, Dr. Shagnik's point about anti-VEGF and nephropathy, this sort of correlation, how much do you give it importance? Do you decide not to do anti-VEGF and nephropathy patients outright? Do you refer to a nephrologist? But before I come to your question, he makes a point over there. Why would you need an FFA for an apparent moderate NPDR at presentation? Question mark. So, Dr. Shagnik, your answer in the question itself. Apparent moderate NPDR. A naive patient may not be apparent, he may be a PDR. So your answer lies in the question itself. Also, sometimes you'll have so much of ischemia, you will have understanding that this patient is not going to do very well. The large patch of ischemia, like what Dr. Rupak Roy showed, it will give you an understanding. So don't throw FA in the bin, use it judiciously, and it's there. So I'll come at a question to Dr. Maiti. Your current approach, real-world approach to a patient with some amount of nephropathy, not on dialysis, and you're advising anti-VEGF.
First of all, seeing the OCT, I think the left eye, there was an hyporeflective shadow behind the upper layer. So that is quite suggestive of some ischemic component. But definitely, if the patient is having some renal function problem, we will not go with the DFA in the first go. After giving 3 injections, if the left eye would have not responded, then we would have planned for an angiography to see whether there is an ischemic macula. But regarding sort of the second question, till now, although there are some reports, till now, anti-VEGF is not contraindicated in patients with nephropathy. Yes, definitely that will be referred to the physician to take care of the nephropathy part, and simultaneously we need to treat the diabetic macular edema.
Thank you, sir.
Thank you. Is Dr. Rupak Biswas there?
Sir.
Yeah, I'm there. I'm here.
Rupak, welcome. Are there any patients, and I'll repeat my question again, are there any patients, treatment naive, pseudophakic patients, where you go straight away for Ozurdex or IVTA and not for an anti-VEGF?
No. As a treatment naive patient, I will still go for anti-VEGF as a first line of therapy. Maybe in very few cases, if you have a even the patient, though it is a treatment naive patient, but if you have a larger cystic spaces, lot of fluid, and hyperreflective spots, so those are a clear-cut indication, and patient is pseudophakic, and there is no history of steroid responder. So filling of all those criteria, if it is coming, probably only in those few subset of patient I can think of giving steroid as a first-line therapy. Otherwise, anti-VEGF will be the first line.
I will extend my question a little bit more. Are there any systemic conditions where you will not advise anti-VEGF? Just for the audience here.
Let me put it regarding the question previously, which is addressed by Dr. Anirudh. So if the patient is on dialysis, then even I have the liberty to use anti-VEGF because patient is already on dialysis. So at that point of time, the hesitation is not there. The hesitation comes when you have a borderline nephropathy which can progress further. So it is always a good idea to discuss with the treating nephrologist that yes, this patient needs of anti-VEGF, and I should be I'll prefer to give anti-VEGF rather than the steroid. So in collaboration with anti-VEGF to take into the confidence of treating nephrologists. So that should be a joint approach, should be the better way of treating it. So if any point of time, if the creatinine level goes up, so they also know that what is happening. So and regarding the similar way, if it is possible to collaborate with the cardiologist as well. If the patient is similarly, if the patient has already underwent bypass surgery or stenting has already been done, so probably in those cases you are more safer towards, because that ischemia part has already been addressed. But again, in collaboration with nephrologist and cardiologist, probably the approach will be much safer, and the patient is in much better way can be treated.
Anurita wants to say something. Please go ahead.
I think the question for Rupokda was like, in which cases you would prefer steroid over anti-VEGF. So I would like to answer that yes, I have quite a number of patients where actually I have given steroid instead of anti-VEGF as a first-line therapy. I think pseudophakic patient with a large serous detachment, and as we see as in the SD OCT, if there is hyperreflective foci, they actually respond pretty well with the steroid. And another second thing, in the present time, where it is very difficult to have an checkup every month and getting for the anti-VEGF injections, I think steroid is a good option. We can think over it.
Dr. Siddhartha, yeah.
Another subset of patient who had a recent history of strokes. Within 3 months, we don't want to inject anti-VEGF.
So the take-home message, exactly what Dr. Siddhartha said. I like to say there's 3 things. I show 3 fingers: 3 months MI, 3 months stroke, and pregnancy. Whichever term, first, second, third term, avoid anti-VEGF. So anybody thinking of anti-VEGF, keep these 3 in your mind. Tell your assistant, tell your optometrist to ask these questions all the time. History of stroke, history of MI, and history of pregnancy. These 3 cases, avoid anti-VEGF at any cost and move on to a steroid option.
Thank you, sir. We have our panelist, Dr. Avnish. Dr. Avnish is a VR specialist. Dr. Avnish,
I will ask Avnish a very important question. Avnish, is there Dr. Avnish there?
Dr. Avnish, are you there?
I think he is logged out.
So we can continue with our discussion when Dr. Avnish, I think he's having some network issues. When he joins in, we can include him in the discussion.
Is there any other panelist whom I've missed out by any chance?
No, sir.
You can
go back to Dr. Anurudha Maiti. He has a lot of experience. Any use you found practically? I'm not talking about the thing in practical purpose, the treatment of diabetic maculopathy not responding up to your choice for the OCT angiography. Has it helped in any cases, OCT angiography?
OCT angiography in DME, deciding the treatment, no. It gives an idea of the ischemic area. But actually deciding on the treatment management, I don't think OCT angiography has much role to play, at least in DME.
Indeed.
Means we
There was a
don't use it in
question.
a
There was a
routine
question.
practice actually.
Right. There was a question. This is a little dicey question. This is a play of words. But Anujit Pal had asked that how do you differentiate between recalcitrant edema and another word he had used. I'll go back to the thing again and ask. So, recalcitrant edema. What is your take, Dr. Maiti?
Initially, I will give 3 to 4 injections of anti-VEGF, and if we see that there is no change in the OCT as far as the thickness is concerned, or the visual improvement is concerned, that is less than 5 ETDRS later, then we might think of changing from anti-VEGF to the other anti-VEGF or a steroid.
Yeah. So, Dr. Siddharth, the specific question was, how do we define recalcitrant edema and how does it different from persistent DME? I'm not sure myself.
Can I add something?
Yes.
Yeah, after 4 injection, if it doesn't respond, then we will say it is a recalcitrant DME, and persistent DME is after 4 injection, after 6 months of 4 consecutive injections. If there is no change after 6 months, if there is no change in OCT, we say it is a persistent DME.
Dr.
That's
Avnish?
according to this definition has come from the DRCR.net protocol.
I think Dr. Avnish has joined. Our panelist, Dr. Avnish, is here.
Yeah, I'm so sorry. I was kind of locked out
sir.
somehow. So sorry for.
Dr. Avnish, can we have your comments, please?
Regarding the same case, I think.
No, Avnish, I have a specific. I know you done a lot of work on this. So I'll ask the question that I asked Dr. Arinit. In diabetic maculopathy, in your experience in your Guwahati and Gurugram right now, do you use OCT angiography in any particular subgroup or subtype of patients? Have you seen any correlation with the angiography, fluorescein angiography, and your OCT angiography? Have you looked at it in a very close manner?
I haven't looked into, but some cases where actually there are some concept about capillary perfusion areas at the level of choriocapillaries. In those sort of patients where, as Dr. Anuruddha sir was talking about, there is some hyperreflectivity on an OCT. In those patients, actually, you can actually go in and look for the FAZ, which you can correlate at times to see the macular ischemia. So instead of doing an fluorescein angiography, you can actually pick up those sort of things on an OCTA, and we can actually tell the patients that what the prognosis could be even after giving injections at times. So.
Right. Thank you so much for giving input. Shibashish, anything else you would like
We have
us
a
to?
question from Dr. Nandini. If the patient is planned for kidney transplant, would we prefer anti-VEGF or Ozurdex?
My answer: let him have the kidney transplant and come back. He'll get better anyways. Actually, I tell the patient, don't waste your money, don't waste your time. Have the kidney transplant, come back, and the fluid goes away. I'm not joking. Dialysis patients, the moment they start dialysis, the edema goes down. Let them start the dialysis. I'm the happiest with patients who go on dialysis. The eyes improve tremendously. Blood pressure comes under control. And in this patient also, he did make a diagnosis of DME. There's a word we used to use 20 years back, 10 years back, mixed retinopathy. Nobody writes that nowadays. This patient definitely had a hypertensive retinopathy also. So it was not just a DME. And because it was a case presentation, I agreed with that. So any patient undergoing a dialysis, starting dialysis or having a transplant, hold on, don't do any treatment. Let them have that and come back to you. You'll have better patients. I can ask the panelists if they have any other opinion.
Yeah, definitely.
I agree fully with you. You know, these patients will definitely improve after a successful transplant. But you know, if this process takes a long time, you can buy time by steroid implant. That would be ideal.
I agree.
Yeah, and at the same time, these are the patients that are having associated other concurrent comorbidity, like anemia is one of the most important factor, like this kind of patient who are planned for nephropathy. So these parameters also to be taken care parallelly along with this transplant time. So that also causes significant improvement of their recovery. Regarding one more point, I think this is Dr. Sinha.
Yes, sir.
Yeah, I'll just make a comment because this is a mixed platform for many of the general ophthalmologists are also here. So regarding Dr. Rupak Roy, what he has presented excellently, and the two things that I would like to mention here. There is no hurry for the cataract surgery when you have cataract and diabetic macular edema. Treat diabetic macular edema as much as possible, as long as possible, and then plan for your cataract surgery. Number one. Number two, if you have instead of a very early cataract operating, if you have a significant cataract and then you operate, the patient also gains a significant visual improvement. So that's how the patient also recognizes the value of cataract surgery also at that time. Third point is that logically there is no increase of the VEGF load by doing cataract surgery. So if you have treated the macular edema well with anti-VEGF before doing cataract surgery, so you can simply add up a steroid pre and post-operatively non-steroidal anti-inflammatory drug by which you can definitely control the macular edema surge during or after the cataract surgery. So these are the three things you should remember regarding the points for treating a patient with cataract surgery, along with good and tight systemic control. And I would like to congratulate to SWB chapter of YOSI. I'm really amazed to see the the kind of work Divakant, Dr. Digvijay, everyone did for last 6 years. This is amazing. I think everyone, all our followers, they have accepted. You have done much more than what we all have done together. Keep it up.
Thank you, Rupak. Dr. Subhashish, I think we can stop with
Thank
that.
you, sir. Yeah, I would also like to, if anyone has any question at the end, anyone can chip in. We have our expert panelists. So if anyone has any doubt on these difficult cases of diabetic macular edema, we can have our last questions here. If not, then I'll hand over to Dr. Vedant. So as we miss our physical meetings, we would have ended it with a wonderful dinner. But in our virtual meetings, we'll need to have virtual dinners. So I'll hand it over to Dr. Vedant to officially end our today's meeting.
Thank you, Saurav sir, and Anirudh sir, Rupak sir, Siddhartha sir, and Avnish for the wonderful discussion that we had. I think all of us have benefited in one way or the other from this discussion. Wonderful to have blessings from all of you. And I think with that note, I would request Dr. Devanjan Sen to give a vote of thanks.
Thank you, Vedant. Am I audible?
Yes, you are. Yes, you are.
Yeah. Thank you, Vedant. It was a long yet wonderful session we had today, the first session of our chapter. Thank you, Dr. Pushpita Sahu, Madam, OSWB President, Dr. Subhashish Nag, OSWB General Secretary, for the extremely motivating and kind words. And a big thank you to the entire OSWB team of senior ophthalmologists for their help and cooperation in setting up this chapter. We are looking up to you for inspiration and guidance in the future. Thank you, Dr. Namrata Sharma, Dr. Rajesh Sinha, Dr. Partha Biswas, representing AIOS, for attending our program and your inspiring words. Thank you, YOSI, represented today by Dr. Digvijay Singh, Dr. Sonal Kalia, Dr. Divakant Mishra, Dr. Karan Bhatia, Dr. Anu June, Dr. Nilutparna Deori, and Dr. Chintan Desai for helping us become a part of the greater scheme of things. Thank you, Dr. Saurav Sinha, for chairing the session and bringing out the vast experience you have to kickstart our first ever state chapter session. And thank you, Dr. Rupakanti Biswas, Dr. Aniruddha Maiti, Dr. Siddhartha Ghosh, and Dr. Avnish Upadhyay, our esteemed panelists for the session. We look forward to learning from you at every step of our lives. Thank you, Dr. Ajay Paul, Dr. Sugata Paul, Dr. Kumar Saurav for attending our session. Thank you, Dr. Rupak Rai, for speaking on a topic that is a common predicament for even senior ophthalmologists and helping us clear our concepts. We look forward to such more teaching sessions from you. Thank you, Dr. Saurav Bose, for the excellent presentation. And thank you all the viewers who logged in to view this. This was our first baby step together. Do keep a lookout for even more information, more innovative steps that we are going to take in the future. stay connected, and we want more young ophthalmologists to participate next time. There will be a few more steps, like we also want to come out with the e-newsletter, e-bulletin, where people can contribute, right, on topics which pertain to ophthalmology and beyond ophthalmology. So before wrapping it up, I would like to make an announcement for our next session. Can sort of please share the slide? And for membership to YOSI, people can visit the YOSI website and also connect to us on the WhatsApp group. So the next session will be on cornea. And there will be panelists and there will be a guest lecture as well as a case presentation. So we are hoping that there's even more attendance on our next session. And thank you, everyone. Stay safe in these unprecedented times. And we'll have a good dinner now anyway. We're at home. Thank you.
Thank you, Devanjan.
Thank you, Devanjan. With that, we'll...
Thank you, everyone.
Thank you so much, everyone, for giving your valuable time. Thank you for and sorry for the delay.
Devang, we've learned so much from you, bhai. Namaste.
Thank you, ma'am. Dr. Devakant, thank you so much for the installation and for the program.
Thank you so much. Let's have a good meal now.
Yeah.
Thank you all. It's really good.